Now? Yes, good morning. So I'm sorry for this delay due to the different adapters, and I was asked to speak this morning on tips and tricks. And after I've seen the different nice talks in the last days, I had to change completely my talk, and then I decided to discuss with you some aspects not really very discussed or covered during this meeting, the relationship between ultrasound and fetal brain anomalies and genetic diseases. So for the warm-up, I want to show you at the beginning how we perform the examination as a basic examination, looking in the axial view of the head to the lateral ventricles, to the shape of the lateral ventricle, and to the cavum septi pellucidi, focusing on the anterior horns, on the pericallosal sulcus, and on the interhemispheric fissure and the falx cerebri. And we know that the shape of the cavum septi pellucidi is rectangular in 3/4 of the cases, and in the study of Viñals from Chile, it showed to be triangular in 27% of the cases. And the next step is to have a look to the posterior fossa, focusing on the cerebellum and the vermis, and seeing the separation between the fourth ventricle and the cisterna magna. But, and this is the basis, many people, sorry. The morning is difficult to speak long, so, and we know in the meantime that we should focus more and more on the cortex, and as you see here, starting with the 20 weeks, half of the gestation, there is the development of the insula as a landmark for gyration. And we knew for years that there are differences between the early and the late brain with different gyrations, but we needed some landmarks and some good studies to highlight this. And I will recommend you the 4 papers focusing on this condition. The first paper from Anstoy, another one from Pistorius, looking to all the different fissures, and the 2 papers from the Guibault group on this condition. This is a kind of important summary on how it looks like. More or less what you should know is that this is a good area to look at the first development of the gyration, to look into the Sylvian fissure. And as a rule of thumb, you can say before 24 weeks, it's kind of wide open, and starting with 24 weeks, it looks rectangular, and after it, it's you see the beginning of the operculization. So this is here roughly views, and this is more and more important for people doing neurosonography. And of course, you have to add definitely a transvaginal approach with the high resolution probe, and some specialists will do it on a routine, others will do it mainly when there is some high risk or something suspicious. So in my opinion, and the supporting opinion of the last days, there is no abnormal brain without a transvaginal sonography or with a high resolution probe. We have heard also from Denise Pugash that if you magnify the image and you have a good resolution and you make it more clearly, you see the lamination observed also on MR to know the normal development. So I'm going to cover with you this morning the relationship between the brain and some genetic diseases. And generally, this is what we were knowing until now. So this is the typical abnormalities associated with the genetic disease, but it's mainly aneuploidies like holoprosencephaly, spina bifida, posterior fossa anomalies, ventriculomegaly, choroid plexus cysts, dysgenesis of corpus callosum, and dilated CSP. And you see here, roughly speaking, that the ventriculomegaly is the leading sign in trisomy 21, while in trisomy 18, we know that it can be spina bifida, it can be choroid plexus cyst, and trisomy 13, the leading sign is anyway holoprosencephaly. And you know, these complex one can have any one of these, so this is what we know. But what we should also emphasize nowadays is that beyond performing a classical karyotyping, performing a microarray shows that in at least between 5 and 10% of the cases, there is an additional benefit getting diseases not detected on a regular karyotype. And a nice study by Lisa Schaffer, published in Prenatal Diagnosis, she splitted the different conditions, and you see if it's an isolated condition or associated with other system, the range changes between 6 and 12%. So in nowadays, if you have an abnormal brain, and I will not discuss this furthermore in my talk, we should, after a karyotype, if it's normal, continue with a microarray in general before thinking of other diseases. And this should be considered in many places today as a standard of care. Now, I decided to take few conditions and to share with you my own experience. So I cannot cover everything, unfortunately, and I want to hurry because we lost some minutes of time. Let's start with the complete and partial agenesis of the corpus callosum and some warm up at the beginning. So it may be not very evident at the beginning, but knowing the typical signs you see already in the axial view, even without the dilation at the level of the posterior horns here, you are able to recognize that there is no cavum septi pellucidity. The anterior horns are compressed. There is the teardrop sign, and there is a dilated interhemispheric fissure. You will confirm the diagnosis by getting a transvaginal view, where you are able to look in this coronal view to the brain, and you see under normal conditions how nice you see the cavum septi. And in these conditions, there is no cavum septi, and the anterior horns are not only compressed, but lateralized. And if you look at the region here and here, you see how narrow it is under normal conditions and how wide is the region between the two hemispheres. And this is something where you can use it also in the axial view. So when you are scanning this condition, you can go a little bit higher than the ventricles to see the so-called too many lines, a typical hint for agenesis, complete agenesis of corpus callosum. So I think, I'm sure people sitting here know this diagnosis, and it is in the meantime so routine you can have it, look at it within a few seconds and you know what's going on. But what about the partial agenesis of corpus callosum? This is really tricky, and we were for years trying to get a longitudinal view, sagittal view to look at it. Of course you will do it, but there may be other signs, and 2 years ago or 1 year ago, there was a paper published by Shen and co-workers who described that the width is larger than the length, and we ran a study instead of saying, roughly speaking, measuring the length of the cavum septi, the width of the cavum septi, and constructing a ratio out of these. And you see under normal conditions how it looks like, but here it is more circular, and it's not yet shifted the ratio, but it's in partial agenesis in this condition. And you can see it, I think it's the last issue of the White Journal, where you can get this curve, and as you see, the length is three times the width of the cavum septi, and in a ratio less than 1.5, it's very, very suspicious. In general, if you have an abnormal shape, you will anyway try to get a longitudinal view, but also to check for additional signs. So this is an example here at 34 weeks. This is the cavum septi like square-shaped, and you look at the longitudinal view, and this is partial agenesis. So this is the first hint. The next is, what about genetic diseases? If you look at the genetic diseases like this, and this is one of the nice papers you can refer to, published by Lynn Paul and co-workers, 2007. This is a short list, but if you look to OMIM, you'll have several hundred conditions. And of course, there is no chance to go through all these. But I want to highlight two because they may be of interest and they made you think. The first thing what I do when I look at corpus callosum agenesis, if there are other associated anomalies, and if it's a boy or a girl. Because typical diseases for a girl could be the Aicardi syndrome, and typical disease for a boy could be the L1-CAM condition. So, and these are written here. You see it's written syndrome with identified genes with the L1-CAM and with no genes, and this is the other condition. So what is about Aicardi syndrome? This is really difficult to diagnose prenatally. Postnatally, it may be easier. It is the typical triad described in the 60s, where you have, in addition to the dysgenesis of corpus callosum, abnormalities in the eyes and seizures. It is only in girls. Boys do not survive, probably. I don't know what is about the prenatal life. And there is, unfortunately, no gene localized yet, so this is only a clinical diagnosis. But later on, there was an update on what is called Aicardi syndrome. You can refer to in OMIM on the gene reviews. And today, I will recommend you to look at these conditions because typically they may have also eye anomalies. So if you see an agenesis or dysgenesis of corpus callosum in a female, look at the eyes. Do you find the coloboma? Do you find macrophthalmia? Look at typically are cysts in the brain. If you have choroidal plexus cyst or interhemispheric cyst, check the cortex, polymicrogyria, typically also asymmetry between two hemispheres. If you have heterotopia, and the spine with costovertebral anomaly. So I show you cases. This is the earliest case I had many years ago. It was an agenesis corpus callosum, and microphthalmia in a girl. We suspected at that time it could be iCardi by the pathologist, but no one could confirm this condition. But if you look at such conditions here, an agenesis and a cyst here, or plexocyst in late gestation, you rarely have a plexocyst in late gestation. This could be suggestive for iCardi syndrome, or a case, and this is what I want to highlight for you and emphasize, simply referred because of a cyst in the brain. You say, oh, don't worry, interhemispheric cyst, it can be operated and so on. But you see, cyst in the brain, girl, look at more and more. And then you see here that the corpus callosum is short. You may think of doing tractography later on, but consider if these two combinations plus a girl could be iCardi, and what to check for. The eyes were normal. What about the brain? And looking targetedly, we saw on one side this, and on the other side, this abnormality of the gyration. Knowing that it's only in the perisylvian region and in the posterior part of the brain, there are the first fissure. This is not normal, and typical also the asymmetry of both. And this is what you see on MR. And this one I have not seen on ultrasound, but these two were seen. So you have now the typical 3 or 4 signs of iCardi syndrome. And it's not an isolated cyst which can be operated. It's already polymicrogyria plus GER plus dysgenesis of corpus callosum plus this condition. So this is suggestive for iCardi syndrome, in my opinion. So I hope you get this first message. The second message is the one with the boys. You know the disease called X-linked hydrocephaly? It is typically in aqueductal stenosis in boys, and we know that 2/3 of the cases, they have this adducted thumb. So we know this, and we know this since years. The first case I have seen, I just realized now, was more than 20 years ago. It was 96, and it was a recurrent case, and we're wondering, why does it happen twice? There is no at that time, we assumed it's spina bifida. It was not spina bifida. It was not infection. So, and the geneticist said, but there is a disease only in boys. Look at the thumb, and I documented this thumb. And at that time, we did not have yet the molecular genetic basics. What you should know, however, is this is not true for hydrocephaly. This is also a condition, as we heard from Caspian a few days ago, also associated. And you see here the gene on the X chromosome, close to the filamin gene, associate also with, how to say, the axonal guidance. And this can also be found in conditions associated with complete or partial agenesis of corpus callosum, like, for example, the crash syndrome. It's not so rare. It's more common than Joubert syndrome, for example. And today, when you see aqueductal stenosis, but also when you see dysgenesis of corpus callosum, it can be this condition, and this is typically what we know. So if you have a boy, if you see a boy, and please check for the thumbs, and in our setting, after the normal chromosomes and microarray, the next step we'll do is this condition, and there are some data saying that it's some around the region of 10% of the cases of ventriculomegaly. So this was the lady. I'm sorry for the images. She was 180 kilo, 180 weight. She didn't fit in an MR or MR machine, but we could see this. She had a previous child from another husband, 10 years old. She divorced and married a new one, and then she had this fetus. And she said, why do I have twice the same disease in 2 different children? And we assumed you are carrier. And there are not many diseases like this, and we look at the thumb, and it was confirmed. And this is the confirmation of the mutation in the fetus in the lady. And this is the images after birth. So now she has 2 handicapped children, and the second husband divorced after delivery, unfortunately. So now she has 2 children with this condition. So consider, this next message is consider L1 chem diagnosis, not only in ventriculomegaly, but if you have a male with a CNS affection, if you have ventriculomegaly of any origin in a boy, if you have a recurrent case in a boy, you know, my brother, the lady told you, my brother have, let's say, birth handicap because of delivery, you should think it could be also maybe carrier for L1 chem. And look at always, I look always to the thumbs in boys. Now we come to holoprosencephaly. Is there anything new to speak to report on? These are the typical images drawn by Gianluigi Pilou and Philippe Chanty. We have the allobar, the semilobar, the lobar, and the interhemispheric variant is not shown here. We know the diagnosis is straightforward. At 22 weeks, we can make it here at 18 weeks. This was a case of triploidy, and this is a case of trisomy 13 at 12 weeks, and we can go even earlier. This is easy said, but I think many people, when they detect this condition, they see it because of a lot of fluid. And if you see such a case, it was 2015, I guess, and referred because of microcephaly. And if you look at the head here, you see that there is an allobar holoprosencephaly. And we were, of course, disappointed because how comes that person scanning, doing biometry, is not able to recognize the FALX therapy? So this is why we put in the list of looking to the FALX and to the cavum septipellucidi this condition as holoprosencephaly, and not all people, unfortunately, are sent to a specialist. So absent septipellucidum, no FALX, and interhemispheric fissure could be also an holoprosencephaly. But what should we know about this condition from the genetic point of view? It could be trisomy 13, the most likely. Here in early gestation, you have a small fetus, you have tachycardia, and you have some additional signs. And everyone have seen similar cases. You have piriform invasive procedure, and there is no abnormal karyotype. Please refer to the paper in Gene Review of Solomon and co-workers, because there you see that there are cases with syndromic conditions like Smith-Lemli-Opitz syndrome, and also some other dominant conditions. But the message I want to provide you, and this is known in the genetic community, that there is a big group of what is called the autosomal dominant non-syndromic holoprosencephaly. So there are almost 16 genes, and this is very important. If you see in holoprosencephaly and the chromosomes and the array are normal, you should continue in this direction, because one of the parents may be affected, and either he or she, they have minor signs or no sign, and they can inherit to 50% another case of holoprosencephaly. And you see here, this is at 27 weeks, the other case I showed you, and it's a pity to see it so late. And in this case, actually, we have done this, and it was a 6-3 mutation, as you see here, de novo. But in this case, I saw an early gestation, it was nothing else, and CVS was first normal, but later on we found a TGIF on the 18th chromosome, which was mutated, but the father had this condition as well, and he's healthy. Because she came later on and said, what should we do? Do you think we should try another pregnancy? He said, yes, the risk is 50%. And these are cases, I asked the patient to come as early as possible, so she came at 9 weeks gestation. I could look at the brain, see that there is no holoprosencephaly. At 11 weeks, the CVS, and there was no mutation. So it is really worth to do it. Next, on holoprosencephaly, there is the face, the typical abnormal face in allobar conditions. So you'll have here the proboscis, the cyclopia, and the no nose, and the cleft, and the sebocephaly, and so on. But if you look at the review of Solomon, the mildest form you may have is in this one or this one. What you see here is what is called the solitary median maxillary incisor. So in the meantime, when I have patients having holoprosencephaly, not typically for trisomy 13, I ask them to show me the teeth. They say, what for? I said, show me your teeth. And I look if one of them has this tooth. Not yet, I didn't find it yet. Otherwise, I would have make a photo and say, please smile, say cheese. I would have done a photo, but anyway. But this is important for you and for me, because in this fetus, 27 weeks, this is normal face, absolutely normal. The distance of the orbits were normal. And this is here, you can see it. You can today very well see the teeth, we can see the tooth germ, and then in this fetus, you see the solitary median maxillary incisor. So the message is, if you know what you are looking for, you can see it. I know that you may see conditions with holoprosencephaly, but when I see fetuses with brain abnormalities, I include always the eyes. The eyes can be informative for Warco workbook, for ciliopathies, for holoprosencephaly, the distance of the eyes, cataract of the eyes may be associated with micro-Warburg syndrome, and then today I look also at the teeth and this condition as well. Now we move to the next part, the next message, the MCDs. We have here roughly 3 groups, the lissencephaly type 1, type 2, and heterotopia. And as you see here, we have, so typical mutations are the LIS1 mutation on the 17th chromosome, the tubulin, and in boys, the DCX and RX mutation. So I will show you some cases. This at 22 weeks. At that time, we said the brain looks normal. This was okay, but because of polyhydramnios and not rarely found in cases of lissencephaly. Polyhydramnion is also observed. We don't know what is the etiology. The same fetus at 27 weeks, you see there is no square shape, and this typical lissencephaly. In addition, you have typically in lissencephaly a thickened cortex. Not thin, it's not atrophy, it's rather thickened. And this was confirmed on MR and on FISH technique, Miller-Dieker syndrome, which is a deletion on LIS1 gene was found. But some deletions are not so large to be seen directly on the FISH. This is why our geneticists, they prefer to run an array to confirm smaller deletion. But in this case, this is another case at 29 weeks. You see here there is no typical Sylvian fissure, a thickened cortex. The array was normal. And in that cases, you should also seek, because it looks like a lissencephaly, to seek for a mutation, which is a point mutation, and this was found in this gene as well. So in cases we have lissencephaly, we have in the meantime panel, but at that time we were checking one gene after the other. And this is here one case with a deletion, another case with a mutation of the LIS1 gene. Another case, and I'm happy that Laurent is sitting here. I listened to his talk many years ago in a meeting, and he was discussing don't focus only on the anterior horn, but also on the interhemispheric fissure, the anterior one. And this case was published in this paper here, and we had practically exactly the similar case. And you see here, referred by Dr. Hartung, and you see the dilated ventricle, but you see the asymmetry of the brain. And look at the cavum septi pellucci, it is really not so nice. And if you look at the fissure here is not normal as well. And looking transvaginally and magnifying, you see the typical square-shaped appearance of the anterior horns. And if you look at here, you see these are typical signs of neurons which did not migrate. And this is typical subependymal heterotopias. In addition, looking more carefully, you see here the abnormal Sylvian fissure, so some polymicrogyria. And if you look at this condition here, the brain was asymmetric because also the basal ganglia were asymmetric. But this was rather seen, honestly, after having done an MR. So the patient went to Daniela, and Daniela said it is so typical for these dysmorphic ganglia. It could be a tubulinopathy, and this was confirmed as being tubulin type B. The same case published by Laurent Guibault had exactly the same tubulin type B. So today, we will not say, because this is typical for tubulin, we do tubulin type B, we'll run the typical panel. As you see here, it was done for LIS1, because the boy DCX and RX, tubulin A, reline, and others. So we have a package of what we call panel, which is used when there is a lissencephaly. Now, a case, we had a discussion, similar case in the last days. The mother had epilepsy. You heard yesterday in my session when I was sharing similar case. She had epilepsy, and we received the patient for a second opinion because of megacisterna magna. And if you look at the latest literature, 2016, saying systematic review, isolated megacisterna magna and Blake's pouches have low risk for associated structural anomalies. So you may say, don't worry, but Catherine Garel, the author here, published this paper in prenatal diagnosis, and honestly, I was one of the reviewers, so this is why I knew the data, what's there, and the correction. So, and she said there is an association between this posterior aspect and periventricular nodular heterotopia. So knowing this, you can then see that this combination, we're not focused on the vermis, but get higher, and you see here the bumps. This is typical nodular heterotopia. And this is a girl, and this case is called F because this is diagnosis, and the MR showed or confirmed on one hand this and this in the fetus, but also the mother had the same. And we know that this is a classical disease because this is filamine gene mutation, you remember, on the X chromosome, and this is only mother affecting girls. There are no boys having this condition. So, and you can refer to many literature on this condition. So this is something known. So if you have a mother having a problem and the fetus have something in the brain, consider filamine as a typical condition of genetic background. But that you don't get depressed, this is a case I saw in an Arab family, consanguineous ventriculomegaly, perineural heterotopias, as you see here. and here. And this at 31 weeks. And guess what it is? You cannot know, because we checked in this fetus or in this child after a few years, 3,000 genes, and no one discovered yet what's going on. So it's not always that you are able to see it. This was on a research basis, but I want to say that sometimes it seemed easy because we show you the case where they had a solution, but not always it's that easy. And you see here there are cases, it's severely handicapped, it has heterotopias and development delay, but it's not so easy to see it. The next is Walker-Warburg syndrome, and here typically is what you call lissencephaly type 2, which is called cobblestone lissencephaly. It is often apparent with severe hydrocephaly. It is autorecessive trait, and typically we find the Z kinking of the brainstem, eye abnormalities, but also cleft and facial anomalies. And a paper published last year by the group of Laurent showed in 4 cases that there are 2 typical signs, what we know, and these signs are on one hand the Z-shaped brainstem, but an interesting view, which is the echogenic band in the pericerebral space. This one can be seen, and sometimes you have the impression, yes, I want to write down it is Z-kinking, but I think this one is more helpful probably in future because it shows that in contrast to the other cases where there is a problem in migration, here there is no overmigration, so the neurons arrived already here, and we don't see the bumps, but we see the effacement of the intracerebral space and these bonds. So we had the case we saw at the hospital many years ago, so 15 years ago, and she got pregnant again, and she came to us, but at that time, no diagnosis was done. And at 12 weeks, she was referred because of ventriculomegaly. And because I'm looking to the posterior fossa, I saw this kinking of the brainstem. It was the likely diagnosis, but she decided to continue pregnancy. And these are the images where you see here this line, and you see here also the Z kinking of the brainstem. The fetus had normal eyes, but had a cleft. Now, I will finish with other syndromes, not typically brain syndromes, but also you can detect them or see them in the brain, like, for example, the tuberous sclerosis complex. Here, typically, and these are cases you detect easier because they have large rhabdomyoma. We know that 90% may have some intracerebral problems, and 90%, 80% will have a mutation either on the TSC1 or TSC2 gene, which is tuberous sclerosis complex on these chromosomes. So, and what we know here is that many of these may be inherited by one of the parents, so ask the family history if they have epilepsy and something similar, and you check also for angiofibroma on the face, and this is here what you can see. These are 2 patients who did not know that they are affected. This lady had, as a child, epilepsy, and he had only chronic headache. So, and the fetuses had this condition. What to check for in the brain? There is also typical 2 signs you can see in the brain, and this is at 23 weeks. Look at carefully here within the cortex, and what you see is nothing because it's not yet there. The same fetus, it was in July 14, the same fetus in August. See now what happens here. And see the bumps, the gyration, abnormal gyration over these structures. So this is why you should know that you can see it after 26 or 28 weeks. So you can try, but you will not see it. The other one is what is called the typical nodules are typically in what is called in locotypico, so in the anterior region here. And this is, you can scan it transvaginally. And this is where I support Gustavo, that if you know what you are looking and you seek what you are looking for, you will find these structures. If you look at them accidentally, there is no chance. And abdominally, no chance to see them easily. So, and the last one I want to finish with, and I'm still on in time, is thanatophoric dysplasia. I added this morning because yesterday in the session we had from Dr. Mitta from Vienna cases showing that you see it on MR very well and on achondroplasia. So this is the diagnosis very well known for us, but it could be interesting for you to exercise your skill on looking to the gyration of the brain. And there were 2 papers a few years ago describing the abnormal gyration, one by Harmgad and one by Phil Glantz from Toronto. And you see here one of the papers showing under normal conditions, this is how the temporal lobe appears. And then you see here in thanatophoric dysplasia, the abnormal and very early gyration of the temporal lobe. And the view, it should be a little bit lower than the one you look at the lateral ventricle, so more to the skull base. And if you look at here at 22 weeks, the area, you see here, and I added the clip, so you see the region of the cerebellum, and you see here the gyration, the abnormal and hypergyration. At this age, you should see only, as you know, the sulcus parieto-occipitalis, but you see here there are a lot of gyration. So typical finding in thanatophoric dysplasia. But if you see it at 22 weeks, how early could you see it? You can also see it at 16, 17 weeks. And this case, look carefully, you see here the signs as 15 weeks because the fetus appeared with a short femur already at 13 weeks and was referred. So at 15 weeks, you see also the polymicrogyria, the temporal one, and you see the platyspondyly here in comparison to the normal spine. So, and this is a comparison, another normal fetus at 13 weeks, and this platyspondyly in this fetus. So if you have short bones, try to look at the brain, try to look at the temporal polymicrogyria on this 15 weeks. Last week before I came, or 2 days before I came, on 12th of September, we had a case with an abnormal short bones at 13 weeks, and you see here the platyspondyly, and look at the brain here. If you know what you are looking for, you see the polymicrogyria at 13 weeks, and this is here, lateral view. Oops, sorry. And I want to show you here at this stage, in the middle, you see here, you see here the polymicrogyria seen at 13 weeks because they are already there. So it's nice to have knowledge and to know within seconds what you are looking for, but this is only the basic of ultrasound. And this is why I had to show you the tips and tricks, and I hope you enjoyed. I come now to my summary. If you forgot some or you were sleepy, it is a summary again. So first of all, I discussed with you the partial agenesis of corpus callosum, showed you the CSP ratio as a hint to detect or as a hint for looking to the corpus callosum in cases of partial agenesis. I told you about Aicardi syndrome in girls, typically with cysts, eyes, and polymicrogyria. L1 CAM is not only in hydrocephaly, but also in ACC in boys. We discussed also in holoprosencephaly, don't think only in the level of aneuploidy, but seek also for the autosomal dominant non-syndromic holoprosencephaly, and occasionally you can integrate the single median incisor as a new sign. Check for LIS1 gene deletion and mutation in cases you have lissencephaly. Tubulinopathy is typical when you have asymmetric brain and asymmetric basal ganglia. Filamin conditions when you have the mother and the fetus having a posterior fossa dilation or periventricular heterotopia. For Warburg, you have autosomal recessive. You will have Z kinking and echogenic outer border. But this can show occasionally some abnormal of the brain because of the eyes, also ciliopathy. So you have two different groups to consider, but I did not have time to discuss ciliopathy this morning. And tuberous sclerosis and thanatophoric dysplasia is for you only that you can encourage your skill to watch what's going on in the fetus. And Isaac Newton said, what you know is a drop, but we don't know is an ocean. And I thank you and wish you a nice day.